welcome to the topic. The topic for discussion is cleft lip and palate. So, what is a cleft? A cleft is nothing but a space or a split which is present between two tissues. So, if the same space or split is present between two halves of the upper lip, it is known as a cleft lip. And if the same space or split is present between two halves of the palate, it is known as a cleft palate. So, in order to understand the topic properly, it has been divided into the following headings: introduction, etiology, embryology, classification, and management. So coming to the introduction, as already said, cleft is nothing but a space or a split which is present between the two tissues. So these cleft lip and palate cases are the most common congenital facial defects, and these are also known as birth defects. So these occur more in males compared to the females, and cleft lip cases are more in males compared to females, and cleft palate cases are more in females. So the left side of the face is more affected compared to the right side of the face. So cleft lip cases account to around 70 to 80% of the cases, and cleft palate cases are around 20 to 30% of the cases. Left side of the face is affected in 80% of the individuals, right side of the face is affected in the rest of the 20%. So in order to understand the topic further, the embryology of the human development should be known. So the embryology mostly regarding the face, development of the face, is important in this concern, basing on which we can understand why the cleft lip and the cleft palate cases occur. So coming to the embryology, we know that there are 5 pharyngeal arches. Initially there are 6, but one is eliminated, which we are left with 5. So among the 5, the first pharyngeal arch, which is nothing but the mandibular arch, is most important, because from the mandibular arch there develops the maxilla and the mandible. So the frontonasal prominence, which is there on top of the stomodium or the oral cavity, is also important because it develops the frontonasal process. The next picture, this picture which is there, it shows you the entire development of the face along with the maxilla, the mandible, and the whole of the nasomaxillary complex. Coming to the first picture, you can see the topmost portion, that is nothing but the frontonasal prominence, which in turn develops the frontonasal process, the second one. The green color one over here is nothing but the maxillary process, and the pink color one structure which is there over here is the mandibular process. So the maxillary process and the mandibular process, as already said, they develop from the first pharyngeal arch, which is nothing but the mandibular arch. In the second picture, you have 2 round structures, these which are divided further into 2 halves. The yellow color portion is nothing but the medial nasal process, and the blue color portion is nothing but the lateral nasal process. These two in turn develop from the frontonasal process. And the center one, violet color one, is nothing but your oral cavity, or the primitive oral cavity, or nothing but stomodium. So coming to the third picture over here, you can see all the structures unite with each other in order to form the nasomaxillary complex. So the green portion over here, you see it joins with the other half, and along with the lateral as well as the medial nasal process. So pink color portion, which is nothing but a mandibular process, on the left and the right side, they unite with each other in order to form the mandible as well as the lower lip. So coming to the fourth picture, this in turn shows the development of the palate. You can see 2 halves, left side and the right side halves, they unite with each other in the midline. That is nothing but your mid-palate and raphe, and the pink color portion over here is nothing but your premaxilla. And the central dot which is present over here is nothing but your incisal foramen. The premaxilla develops from the frontonasal process, and the rest of the 2 halves, the green color portion, were developed from the maxillary process. These color codings are mostly given in order to differentiate each and every structure, and in order to know from which structure these are developed properly. This is a small video which helps you to understand how the development of the face occurs in an individual.
The facial features of the human embryo develop rapidly very early on in pregnancy, beginning around the 4th week after conception. Many of the structures of the face originate from a group of cells called cranial neural crest cells. These cells move in a distinct pattern from the neural tube located in the back of the embryo to create the various structures of the face. Aberrations in the formation or behavior of these cells are the main causes of abnormalities in the head and face. During the first 3 days of development, the fertilized ovum, or egg, is located in the fallopian tube. As it travels down the tube, it undergoes rapid divisions to form a cluster of cells called the morula. These cells then organize themselves to form the blastocyst, and by the end of week 5, the fully formed blastocyst comes into contact with the uterine wall for implantation. During the second week of development, the inside of the blastocyst, known as the embryoblast, becomes 2 layers, the hypoblast and the epiblast layers. Together, these layers form an oval-shaped disc-like structure. In the third week of development, a streak is created on the surface of the epiblast, during which time the cells of the epiblast detach and migrate. These migrating cells create 3 layers, the ectoderm, mesoderm, and endoderm layers, which go on to contribute cells to form all the tissues and organs in the human body. In the 3rd to 4th weeks of development, a cord called the notochord is formed. This induces the cells in the overlying ectoderm to thicken, forming a region called the neural plate along the back of the embryo. The edges of the neural plate elevate to form the neural folds that eventually fuse to form the neural tube. During this process, neural crest cells are formed along the entire length of the tube at the tip of the folding neural folds. Neural crest cells formed from the head or cranial region are called cranial neural crest cells, or CNCCs. These cells multiply and soon start migrating over long distances in distinct paths from the back of the embryo towards the front of the embryo. Once they arrive at their target destinations in the facial regions, CNCCs further develop and mature and ultimately contribute to a substantial amount of the structures in the head and neck region, such as bones, cartilage, and nerves. Growth, migration, and subsequent differentiation of CNCCs are critically important for proper development of the normal structures of the facial region. Soon after the CNCCs reach their final destination, the facial structures begin to take shape externally. By the 4th week of development, the embryo is characterized by 5 facial swellings, the frontonasal prominence, and the paired maxillary and mandibular prominences. These structures are formed in part from the migration and proliferation of the CNCCs from different regions of the neural tube. In a 5-week-old embryo, the nasal placodes, which will go on to become the olfactory system, and the optic placodes, which will become the lenses of the eyes, will form. In addition, the maxillary and mandibular prominences enlarge and grow forward and towards the middle, eventually giving rise to the upper and lower jaws, respectively. In a 6-week-old embryo, the 2 mandibular prominences fuse to form the lower jaw. At this point, the outline of the mouth is visible. In the 7-week-old embryo, the maxillary prominences grow and fuse to form the border of the nostril and the upper lip. Merging of the maxillary and mandibular prominences forms the cheeks and the corners of the mouth. The philtrum of the upper lip and palate are also created at this time. In this flurry of activity in the first 7 weeks after fertilization, the 5 facial prominences give rise to the formation of the forehead and sides of the face, middle and sides of the nose, the philtrum, the upper lip, the palate, and the lower jaw. By the 7th week of human embryonic development, most of the facial structures can be observed. In the next few months of development, the initial cartilaginous skeleton of the face is replaced by bone, and there is an overall increase in shape and size of the different structures of the face. From childhood to adulthood, the face continues to develop through further growth and remodeling.
So that is how the development of the face is seen. So you can see different type of color codings for the frontal nasal process, the maxillary process, and the mandibular process. So these cleft lip and the cleft palate conditions are mostly occur when the processes such as the frontal nasal process, the maxillary process, and the mandibular process fail to unite with each other. The other structure which is there in the center of your upper lip, that is nothing but your philtrum, which is there. So it is formed by the union of the maxillary process on one side with the maxillary process on the other side, along with the premaxilla, along with the central tissue which is formed from the frontonasal process. So if there is failure of joining between the 3 structures, between the 3 processes, that is nothing but the maxillary prominence of the left and the right and the frontonasal process, in turn gives rise to your cleft lip cases. So if it is present on one side, it is known as a unilateral. If it is present on the other side, both sides, it is known as the bilateral cleft lip. So if it is involving the lip only, it is known as a cleft lip, and if it is involving the lip as well as the palate, it is known as cleft lip and palate. In some cases only the palate is involved, if then it is known as a cleft palate. So the next one is nothing but the etiology. These include the factors which are responsible for causing the cleft lip and the palate. So mostly these are multifactorial. There isn't any one factor which can be said that it is responsible for the cleft lip and the palate. So these factors may include the genetic and the environmental conditions, or a combination of both of them. So, and some drugs such as teratogens, they are also known as teratogens or teratogenesis, such as cortisone, methotrexate, dilantin, etc., are also responsible for causing the cleft lip and palate cases. So the maternal age is also one important factor. So consider a mother who has conceived at a late age, suppose 45 to 50. There are chances that the cleft lip or palate might occur in that infant. And if there is smoking at the time of pregnancy, if the mother has a habit of smoking, or if the surrounding people are having the habit of smoking more in number, then definitely it would cause the cleft lip and palate condition. So other conditions would also include the folic acid deficiency. The reason why the folic acid tablets are given at the time of pregnancy is to avoid the cleft lip and palate conditions, and to enhance the development of the overall embryo. So next one is the problems associated. Problems associated if an individual is having a cleft lip or palate. So these problems mostly include the dental problems, aesthetic problems, hearing and speech, and the psychological problems. So in the dental problems, so many problems are included in that. These include congenital missing teeth, presence of natal or neonatal teeth. You know what are neonatal teeth? Neonatal teeth are nothing but the teeth which are present at the time of birth, itself. So presence of supernumerary teeth, ectopically erupting teeth, anomalies of tooth morphology, enamel hypoplasia, microdontia. Microdontia nothing but small sized teeth, fused teeth, aberrations in the crown shape, such as a mulberry teeth, mulberry molars. Next, macrodontia. Macrodontia is nothing but increased size of the tooth, mobile and early shedding of the teeth, posterior and anterior crossbites, protruding premaxilla, deep bite, and spacing, as well as crowding within the teeth or within the arches. So these are the problems which are related with the dental. Coming to the aesthetic, yes, the aesthetics of the face is also affected because there is no marked union between the structures of the face. That is nothing that includes the nasomaxillary complex. The left side of the face is not markedly mixing with the center of the face. So due to which what happens that there is deformities which affect the nose, size of the nose, the width of the nose, and the height of the nose is affected, and even the maxilla is mostly affected in cleft lip and palate cases. The maxilla shows dormant development, due to which there is retrognathtic maxilla in the central part of the face. You know that face is divided into three halves: upper half, middle half, and the lower half. The middle half of the face is mostly affected in cleft lip and palate cases. Hearings and speech problems are also present in these individuals. These mostly include the disorders of the middle ear, which may affect the hearing, and also the language intake as well as speech is also affected, because there is a hole in the palate, due to which there is lack of proper pronunciation of the words. Psychological problems, yes, definitely the psychological problems are there for the individual, because they face a lot of problems in obtaining, in making friends, as well as they don't have much of attire to join with others, and due to the abnormal facial appearances, they put others upon staring, as well as curiosity and pity would be there with the others onto them. So due to this, the psychological development is also affected, and both for the parent as well as the individual. Next, coming to the classification. This classification, the topic is very important, because these are mostly given for your exams. So the classifications, there are multiple number of classifications which are present. These include, the first one is the Davies and Ritchie classification. So according to this classification, it is also known as a morphological classification. The position of the cleft is assessed in relation to the alveolar process. So this classification includes three types of groups: group 1, group 2, and group 3. In group 1, we have the pre-alveolar clefts. In group 2 you have the post-alveolar clefts, and group 3 there we have alveolar clefts. So if a cleft is present in front of the alveolar region, in front of the alveolar ridge, it is known as pre-alveolar cleft. If a cleft is present behind the alveolar ridge, it is known as post-alveolar cleft. So if a cleft is present on the alveolar ridge, including both the lip and the palate, these are known as alveolar clefts. So the group 1 cases include the cleft lip conditions only. Group 2 cases include the cleft palate cases. Group 3 condition includes all the cleft lip and palate cases. Means cleft is involving both the lip and the palate entirely. Next classification is the VU classification, VEAU, VU classification. So in this we have 4 groups. The first Davis and Ritchie classification has 3 groups. The VU classification has 4 groups. The first, this is in reverse to the Davis classification. So in this, the group 1, class 1 is the classification which involves only the cleft with the soft palate only. The second class includes the soft and the hard palate. The third one includes complete unilateral of the soft, hard palates as well as the lip and the alveolar ridge. So in the class 3, there is a cleft which involves entirely the soft, hard and the lips along with the alveolar ridge. Class 4 has a complete bilateral cleft. So we have 4 classes in VU classification: class 1, class 2, class 3 and class 4. In class 1, the cleft is only with the soft palate. In class 2, the cleft is involving both the hard as well as the soft palate. In class 3, there is a complete cleft which involves soft palate, hard palate, alveolar ridge and lip. In class 4, we have a complete bilateral cleft which involves on both the sides. So next classification, coming to the next classification, we have a picture which represents the previous classification, that is nothing but the VU classification. In the first picture you can see the cleft is involving only the soft palate. In the second picture you can see the cleft is involving both the soft as well as the hard palate. In the third picture you can see third classification. This third picture is nothing but third classification. The cleft involves soft palate, hard palate, alveolar ridge as well as the lip. In the fourth picture, which represents the class 4, there is a bilateral cleft present. Coming to the next classification, we have Carnahan's and Stark stripped Y classification. This is a very important classification. So in this you can see a Y-shaped strip which is present. You have different blocks in that. Totally 9 blocks are present, which are numbered from 1 to 9. You have 2 sides, that is right and the left side. So coming to the left side, you have 3 blocks which are numbered as 4, 5 and 6. This central portion is nothing but the incisal foramen. On the right side you have 3 blocks, 1, 2 and 3, and on the lower side of the incisal foramen you have 7, 8, 9. So these 9 blocks consist the Y-strip classification. So each and every block has a certain nomenclature. So the 1 and 4 on both the sides represent the lip, the 2 and 3 on both the sides represent the alveolus, and the 3 and 6 on both the sides represent the palate anterior to the incisor foramen. The 7 represents the hard palate, anterior portion of the hard palate, and 8 represents the hard palate, which is the posterior hard palate, and the 9 represents the soft palate. So basing on the cleft, presence of the cleft in the intraoral region, we will be marking the areas which are involving the cleft. So if one is there, blocks such as if a cleft is present on the lip on the right side, we will be marking the block 1. If a cleft is present involving both the lip and the alveolus on the right side, we will be marking both the 1 and 2 blocks. So if a cleft is present involving 1, 2 and 3, all the 3 blocks on the right side, we will be marking the right side blocks. So if a complete cleft, unilateral cleft is there, 1, 2, 3, 7, 8, 9 are marked on the right side. If a cleft is present on the left side, alternately we will mark the blocks on the left side. Next classification, that is nothing but Lashal classification. The spelling over here is having a mistake. It should have a H over here. So this is also very important classification. You can see each and every alphabet represents one structure of your intraoral region. So the first L which is there, it represents the lip. The second A represents the alveolus. The H represents the hard palate. The S represents the soft palate. Again, there is a repetition of the same alphabets which are present on the right side. This entire portion is your right side, this entire portion is your left side. So we start from the patient right and end with the patient left. So this entire portion is the right side, this entire portion is the left side. So again, the first one, the L is the lip, A is the alveolus, H is the hard palate, S is the soft palate. Again, A is the alveolus, L is the lip on the left side. So areas which are affected are marked or blocked on the same block which is representing the condition. So if another 2 points which has to be noted in this classification are, we have capital letters as well as small letters. If they are capital, then it is complete, the cleft lip or palate is complete. If they are small letters, the cleft lip and palate are incomplete. This classification was first given by Occurrence in 1987. You can have some example in the next slide. So all these are the examples of the cleft lip and palate conditions which are involving the enteroral cavity on both the right and the left side, both complete as well as incomplete. The first one, you can see all are capital letters on the right side. So it is right, unilateral, complete, cleft, complete because you are having capital letters over here. Complete, cleft lip, complete, cleft alveolus, and complete unilateral cleft palate. Cleft palate because both the hard as well as soft palate are involved. It is only on the right side. That is the reason why it is unilateral. Over here in the bracket, you can see VU class 3 classification is also mentioned. So VU class 3, it is unilateral, involving all the structures of the enteroral cavity. The second example, coming to the second example, you can see small L is there, small a is there, again capital H and capital S. The cleft is present on the right side, but small L and small a state incomplete cleft lip and cleft alveolus with complete unilateral cleft palate. The H and S represents the hard and soft palate. In the same way, the rest of the examples also do explain the condition. So you can go through the topic in the later times where you can understand the Leschel classification properly. So in this way, you can represent the condition of the cleft lip and palate for the individual. So there are other two classifications which are not that much important. They are Fogg-Anderson classification. In this we have again three groups, group 1, group 2 and group 3. Group 1 represents the cleft lip, group 2 represents the cleft lip and palate, group 3 represents the cleft of palate up to the incisor foramen. So this is almost the same as of your Davies and Ritchie classification. So in this group 1 for Fogg and Anderson classification, you can see U by B. U is nothing but the unilateral, B is bilateral, single as well as double. So the next classification is Schuchard and Pfeiffer classification. In this also you can see there are 6 rectangular blocks. 3 are divided onto the left side, 3 are divided onto the right side, and there is an inverted triangle which is present. So upper 2 blocks represent the lip, the upper 2 blocks represent the lip, the second 2 blocks represent the alveolus, the third 2 block represents your hard palate, the inverted triangle represents the soft palate. So once the chart is prepared, we will see the condition of the individual and we will mark it totally dark if it is a total cleft, and we will mark it slightly dark if it is a partial cleft, that is incomplete cleft or of the lip or the palate. So next is management of the cleft lip and palate. So once you know how the cleft lip or cleft palate has occurred, you need to go for the management. So the management of cleft lip and palate is a very complex process because it involves a lot of structures. The lip is there, the palate is there, the incisor foramen is there, as well as central philtrum is there. All these structures are to be managed properly in order to get a proper facial prominence as well as facial profile for the individual in order to improve the aesthetics of the individual. So in order to achieve all these things, a multidisciplinary approach formed by a team of different doctors or different professionals is important and is required. So this team includes a pediatrician, an orthodontist, oral and maxillofacial surgeon, otolaryngologist, simply known as a laryngologist. So it's nothing but a professional who is more concerned about the pronunciation of the words or improvement of the speech, and audiologist, basing to the ENT specialist, also known as ENT specialist, who is concerned with the ears and all. The speech pathologist, if there is any speech difficulty or if there is any mispronunciation of the words, he would give the speech pronunciation therapy. A social worker, which includes the nurse and the supporting staff, a psychiatrist if any psychological problem is there for the individual. A genetic scientist is also required if there is any condition of the cleft lip and palate due to the genetical condition or a hereditary condition. A prosthodontist is also required, which you will know why a prosthodontist is required in the next slides. A pediodontist is definitely required because mostly the cleft and palate management starts at an earlier age in infants. The pediodontist is much required for managing the patient. A radiologist, of course, is required for taking the required x-rays and all. A neurologist and a neurosurgeon is required for if any nerves or correction of the nerves and any surgeries are required. Definitely in regards to the nerve innervation and all, a neurologist as a neurosurgeon is required. So the management of the cleft lip and palate is done in 4 stages. First, stage 1, stage 2, stage 3 and stage 4. Stage 1 management is done between the ages of 0, that is just born, to 18 months of age. Stage 2 management is done between the ages of 18 months to 5 years, and stage 3 management is done between the ages of 6 years to 11 years, and stage 4 is done between the ages of 12 years to 18 years. Coming to the stage 1 management, so this has 4 subheadings or 4 stages of management, again sub management stages. So first stage includes maxillary passive obturator, fabrication of the maxillary passive obturator. It is done with the cold cure appliance. Next one is the pre-surgical orthopedics. That is nothing but your NAM technique. NAM technique is nothing but naso-alveolar molding technique. Next stage includes the surgical lip closure. Last stage includes surgical palatal closure. Coming to the passive obturator, which I already said, initially prosthetic appliance which is made up of cold cure is given to the baby in order to facilitate or fill the space or fill the roof which is already having a cleft. This helps in facilitating the suckling habit or the feeding habit, and also if there is any breathing problem for the infant and all, is corrected with the help of a passive obturator. As already the word said, obturator, it obturates the space which is there such that it allows the baby to feed and suckle properly. It also helps in maintaining the maxillary arch form, and if any stability is required for the maxillary arches, because as already said, in cleft lip and cleft palate cases, both the halves of the left side and the right side do not meet with each other. So there is a space between them, and there are chances that they collapse. In order to avoid that collapsing, we will give a passive obturator made up of acrylic plate, which holds the 2 parts, left and the right parts, in proper condition and helps them from collapsing, prevents them from collapsing. So the second picture over here, this represents the exact procedure which is carried out for fabrication of the passive obturator, maxillary obturator, which helps in feeding and suckling for the infant. If you can see the first picture over here, you can see there is a complete cleft which involves the lip as well as the palate. This is a complete unilateral cleft involving the lip and the palate. Second picture, you can see an impression which is made of the oral cavity of the infant. Third picture, there is an appliance which is made up of a self-cure as of you make your primary impression for the CDs and all. In the same way, we make a primary impression and we make a custom tray for that. So once the custom tray is done, then we'll go for the secondary impression and the secondary cast is made. On this secondary cast, we'll go with the secondary fabrication. That's nothing but your exact fitting processes, which is made to fit into the infant's mouth. You can see an attachments which are also present to the appliance. These attachments are fixed to the cheeks of the infant such that they don't move in the oral cavity. It helps, or it prevents the intraoral appliance from moving, and it holds the intraoral appliance in position. These two are attached to the cheeks and a plaster is placed on the cheeks. The second picture over here represents the same one, the final stage of passive obturator, which is placed into the infant's mouth. So once the passive obturator is placed, you can see complete closure of the cleft is there, and 2 projections are there from the obturator. These 2 projections are bent down onto the cheek, and they are attached with the help of a plaster onto the cheek. This helps in feeding and suckling habit for the individual. So once the passive obturator is given for some months, then we will go with the pre-surgical orthopedics. That is nothing but the NAM technique, naso-alveolar molding. The name itself suggests we will mold the 2 structures. That is, we have 2 structures present between the cleft, present on either sides of the cleft lip and palate. The greater structure and the smaller structure, that is nothing but an alveolar ridge which is present on either sides of the cleft. So the large part of the alveolar ridge which is there, it is known as the greater segment, and the small part of the alveolar ridge which is there on the other side is known as the smaller segment. So these two, definitely you can see in the lower picture, there are two halves over here. So this bigger half is known as the greater segment and the smaller half is known as the smaller segment. So if a cleft is there, suppose a cleft is there involving the lip and the palate, the alveolar ridge is separated into two halves by the cleft. So greater segment and the smaller segment. So the name as suggesting nasoalveolar molding, you have already given a passive obturator to the individual. That passive obturator is molded in such a way that you can get the two segments unite to each other. You can approximate both the segments. You can get the greater segment as well as smaller segment towards each other, such that you can give a proper form to the alveolar ridge. This further in the later stages facilitates in the pre-surgical dip procedures and the pre-surgical palate procedures, that is surgeries which involve the closure of the lip as well as surgeries involving the closure of the palate, because the space or the cleft is closed, the cleft is brought down to a minimum, the space is brought down to minimum. It would be easy for the surgeon to do the lip surgeries as well as the palatal surgery. So these are different types of NAM appliances you can use. Initially, you see this first picture represents the condition of the infant. This is the appliance which is made. You can see a U clasp which is there over here. So in order to get all the three segments to a form, to a shape, you can compress this U which is there. This U on the either sides of the appliance, you can compress them such that the anterior part is combined with the posterior two halves which is there. So another type of appliance, you have a Hyrax screw which is present in the center. Once you tighten up the Hyrax screw, it would bring the anterior portion back towards the posterior portions. This one is also the same, third picture is also the same picture which has a center Hyrax screw. If you tighten it up, the anterior portion is brought close to the posterior portions. So next step which is involved in the stage 1 management is the surgical lip closure. So with the help of the passive obturator, once the two segments or three segments which are there, once they are brought together, once the space of the cleft which is there between the structures is decreased, then surgery for the lip is planned initially. There are two schools of thought for this: early school of thought and late school of thought. In early approach, we have a lip surgery which is performed after the 45 days, because some segment of the doctors believe that the immunity of the individual, immunity of the infant is more at early stages. But some segment of the doctors believe the late approach is much appropriate compared to the early approach because of the rule of 10 which was given by Millard. So after it is mostly done at the age of 2 weeks, 10 weeks. 10 weeks mostly it would be around how much? 2 months, mostly 2.5 months. So according to Millard, the rule of 10, the baby should be at 10 kgs of weight. The hemoglobin of the baby should be 10 milligrams per dl, and the age of the baby should be 10 weeks. So this rule of 10 was given by Millard. Very important, very short answer. So some of the doctors, they prefer that a late approach for the surgical lip closure is much advantageous compared to the early approach. So both of the approaches can be done depending upon the orthodontist and the other doctors which are forming the team. They decide on the factor which are important for considering for the individual. Either the early or the late approaches can be done for that time. The late approach is mostly done because a lot of tissues come into a good development during the late approach. You have a lot of tissue to operate. It is better if you do it in a late stage because of the developed tissue which is there. So once the lip surgery is done, then the palatal closure is also planned accordingly. So once the baby or the infant achieves around 1 year to 2 years, so it is mostly planned after the 2 years especially. So once the baby is between 1 to 2 years or after 2 years, a bone transplant is bone transplant for the cleft or the space which is present between the alveolar ridges is planned. So bone transplant, which is mostly taken from iliac or symphysis or the rib or the tibia, is taken, and it is placed between the two structures which are not uniting. So into the cleft, the bone is transplanted, and then a palatal closure is done. So once it is done, there is expectation for the closure of the palate as well as the lip. Initially the lip surgery is done in order to get a proper form for the alveolar ridge, both the greater segment and the lesser segment, and they get into a proper shape once the lip is closed. So once the lip surgery is done, then the palatal closure is done with the help of bone transplants into the cleft. So once the stage 1 has been done, coming to the stage 2. So as already said, stage 1 management is done at the ages of 0 to 18 months. So stage 2 is done at the age of 18 months to 5 years. So it is mostly at the stage of primary dentition. So the adjustments which are required for getting the teeth, deciduous teeth, into the proper occlusion has to be planned. So the obturator which is there already in the oral cavity, the modification of the obturator or placing of any holes into the obturator can be undertaken at this stage, such that the deciduous teeth will enter properly into the oral cavity and they can be brought into occlusion. So coming to the third stage of management, this is mostly done during the mixed stage at the age of 6 to 11 years. So this at this stage we have a mixed dentition. So removal of fixed appliances can be given in order to fixed appliances, that too mostly the functional appliances which are planned, they can be given at this stage in order to correct the maxilla as well as the mandible. So mostly the cleft lip and palate, you can observe retrographic maxilla or undeveloped maxilla is present, or in some cases the mandible functionally is brought forward by the individual because of the deficiency of the maxilla. So the removal of fixed orthopedic appliances or functional appliances are given at this stage in order to prevent the mandible from going forward, as well as getting the maxilla out such that the maxilla and the mandible are brought into line and the profile of the individual can be improved at this stage, because maxillary correction, retrographic maxillary correction, should be done at a much earlier age compared to the mandible. Coming to the next management, that is nothing but the stage 4. This is mostly done at the ages of 12 to 18 years of age. So this is mostly done at the permanent dentition stage. The fixed orthodontic appliances along with orthopedics is done, along with maxillary functional appliance as well as mandibular functional appliances are done. Fixed appliances is used in order to get the teeth into correction, teeth into occlusion. Cross bites which are present, they are also corrected. Anterior cross bite, posterior cross bite, crowding, uneruption of the teeth, etc. Are corrected with the fixed appliances. The skeletal disproportions, if they are present in regards to the maxilla, in regards to the mandible, they are corrected with the help of orthopedic appliances. If there are any missing teeth or if there is any cleft still present, we will go with the fixed or removable processes in order to cover the space which is there. So once the management is done, the permanent retention is always required in cleft lip and palate cases, because there is the bone which is present or bone which is placed into the palate or into the cleft is not that much as hard as the naturally developed bone. So in order to avoid collapse of the arches, or in order to avoid occurrence of the cleft lip and palate condition again, cleft lip mostly doesn't occur again, but the cleft palate, even though the bone is transplanted into the space, there are chances that the bone gets resorbed again. So in order to avoid those conditions, in order to avoid the force onto the transplanted bone, a permanent retention has to be planned to the teeth. Once the teeth are corrected with the fixed appliance, a permanent retention is given on the lingual side of the teeth in order to prevent reoccurrence of the cleft in the palate. So this is how the management of the cleft lip and palate is done. So the final takeover point is cleft lip and palate, how the cleft lip and palate happens due to the malformation or malunion between the different structures, processes of the head and neck region. So that should be explained. So once the embryology is explained, then you will go with the factors. So once the factors is explained, then the management. This is totally the cleft lip and palate condition. Thank you.